So over to dropped IOLs and nucleus drop as well.
Thank you so much, sir, and thank you, organizers of AIOC, for giving us this opportunity once again. I think we have doing this course for many years in AIOC as well as in a lot of international conferences. So just to understand a couple of principles, no financial interest in my talk. As has been pointed out time and time again, first of all, whenever we all of us can have a problem, and whenever we have a problem, we should not panic. And the basic principle here is all of us should be well versed with good bimanual anterior vitrectomy. So the importance I don't have to highlight here is, but the basic thing is you need to separate the irrigation and the aspiration port, and also leave the main phaco wound. So we should not be handling through the main phaco wound. We will be toileting this wound and suturing it. And once we are well versed with this, a lot of machines are available for doing this kind of a procedure. But the most important thing is this cutter should be there in the pupillary axis. You should not be chasing the vitreous. The vitreous should come to you. That is the first principle. Always make sure that this cutter port faces you. That means the corneal endothelium. Once you make sure all these things are right, there is no way the vitreous you are not be able to cut thoroughly. And whenever we are using tricot, try to use a diluted tricot after doing little bit amount of vitrectomy, so that you have less vitreous to cut there, and then the rest of the maneuvers you can follow. So this was point number one. Point number two is avoid many complications if you have landed in one. So as in this case, what you can see here, the surgeon has implanted multiple IOLs. This was one from the antechamber which came out. Then we saw there was one hanging with the partial bag. So these kind of a thing, whenever you have a problem once, try to avoid it increasing it manifold. So these are a couple of things which we can avoid it. Again, most often or not, if you have a long OT list, or sometimes you are not too careful, this is a carelessness of a surgeon. What you can see here, the bag is not there and they are implanting the lens into the antrovitreous surface. So this kind of maneuvers can be avoided, and once you notice this, the immediate attention has to be paid as how are you going to get rid of the situation. So the trick here was to call a VR colleague and take a help out, but this surgeon tried to fish it out and not been so successful. So this kind of carelessness attitude should be avoided. Always be careful that the phaco wound, once you have a problem, there can be a wound burn, the corneal can be edematous, and multiple things can go wrong on this step as well. So proper good wound dilating, even if you don't have a good antrovitrectomy setup, just as antrovitrectomy with Warner sometimes is enough by use of tricot. Then what we are advocating nowadays is, this was a suggestion given by Abhayasar about 4 to 5 years back. Rather than doing what we are doing it here, or usually what we do is a limbal approach. Rather than doing a bimanual vitrectomy on a limbal approach, why can't we go, all of us can go on a pars plana approach. So what we need here is one trocar and one cutter port. We don't need a 3-port vitrectomy, which is a standard of care. What we are doing here is making a kind of a direct entry. This is a 25 gauge trocar system with Alcon, but you can use it any system. It's not that you need to go on high-end instruments. So you can make a direct entry through the pars plana route, direct this entry towards your towards the optic nerve, as what we are giving normally for doing for intravitreal injections. All of us are giving intravitreal injections nowadays. So once you achieve this, there is a irrigation port here and the cutter port here. Then you go from the back. The whole idea here is, whenever we do a limbal approach, we are cutting vitreous from top to bottom. So that means there can be some kind of a traction when you are exerting on the vitreous base. When you go to the pars plana approach, you are cutting vitreous from back to front. So here there is no traction on the vitreous base, and you are in a much more controlled and a safer environment. So as you can see here, there is a large PC tear lying down here with a lot of vitreous which is there, and the IOL has been subluxated to one side. So once we do an adequate antrovitrectomy, then we can tackle this IOL, and there are multiple ways to fix it up with handshake technique, and then you can decide what best you want to do it. So the whole idea is for all of us to get well versed. As Amar sir already pointed out, instead of putting here, you can have a trocar ACM, so that saves you one port. You can do that as well, and make one port for a vitrectomy for a posterior approach. Now, whenever you have a hydrophilic or a hydrophobic IOL, there are challenges to remove them in a separate subset. So this was a hydrophilic IOL with a bag which has gone inside. So we don't have to really chase the IOL at the first instance. Do a good amount of vitrectomy as far as possible. Try to induce a posterior vitreous detachment, and once you have done that, then the IOL bag removal complex becomes, IOL removal with a bag, capsular bag complex becomes very easy. In one go, you can catch hold of the IOL with the IOL holding forceps, or you can even use a high vacuum suction and bring the IOL into the anterior chamber. The challenges lies with rigid IOLs, especially because the rigid IOLs are difficult to grasp, more so when they are lying, kind of vertically on the retinal surface. This IOL was lying straight bang on the vertically on the retinal surface. The whole idea is not to disturb vitreous too much here, otherwise it will just, IOL will fall on the surface of the retina, and because of the, the rigid IOL are little sharper, the haptics are little sharper, it can tear the retina quite easily. So before tackling this IOLs, just make sure that you could do a good vitrectomy all around, then only catch hold of the IOL and try to remove this up. Another thing is, don't use, whenever we get a problem, we sometimes panic and we keep using reagents which are not meant to be used multiple times. So this surgeon has used trypan blue so much that the entire vitreous cavity was got stained blue with the trypan blue. And what you can see here, the visualization when we perform vitrectomy was quite poor. So these kind of maneuvers should be avoided and best left for the management of a VR surgeon. And this is a trocar ACM, which was an olden day technique. Nowadays we don't use this, but that time this was available with us and we used for this particular patient. Associated retinal problems intraoperatively or even pre-existing can happen. This patient already had a proliferative diabetic retinopathy with vitreous hemorrhage and a cataract, had an eventful surgery. So managing these patients becomes little challenging, as you have to handle not only the IOL related complications, but also you have to handle the retinal complications. So this kind of a technique should be left best for the management of a vitreoretinal surgeon. Again, this patient had a very poor retinal view because of corneal edema. Too much of tricot was used. It decompensated the cornea. As you can see here, the view is very poor. Barely you are able to see the optic nerve head. And when we try to do vitrectomy for this patient, make sure always that the posterior vitreous detachment is complete. Then only try to manage the what you call intraocular lens. Pediatric cases, we have to be little careful, and as rightly mentioned on in special situations like where you have a pseudo exfoliation or a marfans and so on. So capsular elasticity or rigidity both play important role. As in this case, the surgeons was little again not very careful, though did a good PCCC, but when implanting the IOL went inside the vitreous cavity, and we retrieved the IOL back at the same setting and implanted it into the back. This was a couple of rare cases where the reticert implant, intravitreal implant went inside along with the IOL back complex and some sombering rings here. One of the rarest complications we have ever see here. But why I put this case was because all these things, all these tissues are very slippery to remove from the eye. So you need to be very careful and very gentle, otherwise the entire retina can get detached and you can land up in more severe problems. One last sketch which I wanted to show you here is this patient had a nucleus drop on table. It was a grade 2 to 3 cataract. The entire nucleus with the bag went down after the first trench. What we did here is, this was a case done by me and Dr. Sujata Mohan combinedly. We did something differently here. We finished off the glued IOL part rather than removing the nucleus first here. So as you can see here, we are making the conjunctival opening and the flaps. This is a routine. There is nothing special in that. We went ahead, did a little bit amount of anterior-vitrectomy through the phaco wound itself because the trocar infusion was in place, and went ahead and performed a nice glued IOL because we were quite sure, but there is no vitreous, much of vitreous here because the entire back, the nucleus along with the back went inside. Once we finished with this kind of a glued IOL, we toileted all these wounds, didn't put a glue at this stage, but did a good amount of anterior vitrectomy using tricot. Make sure that there is no vitreous again in the anterior chamber. Place little bit amount of glue. You can even wait at this step, but if you are comfortable, you can place the glue also. Then made the vitrectomy, another 2 vitrectomy incisions, went inside and managed the nucleus. So the nucleus can be managed with a cutter in these cases because the nucleus is not that rigid. So as we can see here, in the nucleus drop case, the glued IOL is already in place. And then you go inside and manage the rest of the case. This was a nucleus which was lying on the surface of retina with little bit of tricot which has fallen back. But with the help of cutter itself, we can chew this nucleus quite easily. And at the end, the case looks very good. This patient had a 6/6 vision post-operatively day 3. this is how it looks post-operatively. So this kind of a special situations where according to the situation, the importance of showing these cases, we need to react according to the situation. Don't have a preset rule that we are going to manage the same way what we have learned in the past. So managing complications should be done with a careful assessment and planning. Understanding the principles of management involved are very important. You can do a same sitting or multiple sittings, that doesn't matter. A good teamwork is very important. These are my acknowledgements, and thank you once again, sir, for the wonderful opportunity and for a packed hall as well. Thank you so much.
Thank you, Manoj, for the nice, I think, yeah.
Someone is asking a question. Yes, please, please.
We're not able to hear you, ma'am, because of the
Cut and
background noise there.
Yeah.
So,
Hello.
yeah.
It is always said that go through pars plana while doing anterior vitrectomy. Okay.
So you are saying like
Hello.
the principle is cut and aspiration.
Yeah. So if it is cut aspiration mode always, then isn't it achieving the same goal?
No,
Why
no.
always go from pars plana?
That
Why
doesn't-
can't we go from the AC if it is having cut aspiration mode?
You can go through AC also, there is no problem, but while going through the pars plana, the advantage here is you are not causing too much of traction on the vitreous base.
Yeah, but we are using
And the cut aspiration is on your linear foot
Can you
control.
ask somebody to stop that sound?
The cut aspiration
yeah.
is on
Yeah,
a
sound
linear
that.
foot control. So you can add, actually, adjust that. The most important thing here is you need to understand is the infusion bottle head should be minimal. So normally we keep it about 20 millimeter or 30 millimeter max. The cut rate should be the highest possible with the machine available, and the suction should be the lowest possible.
Yes, but then we can do with going
No, I
anterior
can I
also.
explain that? Do you mind? See, when you do an anterior vitrectomy from the vitreous, you're pulling the vitreous into the anterior chamber. You just imagine it's like a volcano which is coming out, and you're chopping. When you go from the pars plana, you're chopping it off here. Whereas when you're doing it from the anterior vitreous, you're pulling more and more and more vitreous.
But in cut aspiration mode, there was cutting and then aspirate.
No, madam, no.
Even
Even then,
then,
because you are
it's
coming from
manual.
top, you are coming from the top, because of that you are pulling actually. You are pulling the vitreous, and more and more vitreous will
If you have
come.
a small vitreous presentation, it's okay to do an anterior vitrectomy. But if you have a very large vitreous prolapse, the best thing would be to stain the vitreous and go post. See, I'm not saying everybody can do it because this is a posterior segment issue. People may not be knowing how to do a pars plana approach. So, I mean, whatever best you can do is good enough. But if you can approach through the pars plana, that will be the best, because then you are just cutting it off where it is. So it falls back instead of keeping on pulling it, because vitreous is like a slinky. It keeps
Yeah.
on coming up.
No, I think the point you said is valid, ma'am. If you have a small rent with a little bit of vitreous, anterior approach. But when you have a large thing, sometimes when you're putting it through anterior approach, it can also extend the
Yes.
rent also.
Extend the rent also. I think, yeah.
According to the case, I think.
So, madam, if you're doing pars plana vitrectomy, then is it mandatory that we should have a pars plana irrigation also?
Yes.
No. You can have an ACM.
You can have an ACM.
ACM. You can have a ACM.
ACM, you can use a binder.
See, I'm not saying that pars plana is the way to go. Please understand, that's not the message here. The message is pars plana is better than if you're seeing. If you've got access to pars plana, if you're able to do a parsing, I think it's probably better. But you can do very well with a limbal approach also. As madam rightly said, it's very good this thing also. Only thing is you need to use a very high cutting rate. Don't move the vitrectomy probe very fast, rapidly. Just keep it there. As Manoj rightly said, allow the vitreous to come into the port, making sure the port is facing you. And ACM also should be there.
Stain the
And all
vitreous.
the phaco machines are now coming up with fairly good, I think the 23 gauge cutters are available. All the phaco machines are equipped now. So you cannot say that I don't have the cutter and all that. So use automated vitrectors. Don't use the sponges, don't use the devakers. That is going to produce more traction. And don't try to sweep the iris with the rod. So I think put tricot and make sure that you just remove the
And have
vitreous.
separate infusion and separate cutting. That is
Absolutely.
also, bimanual is